So today I'm going to lead you through an illustrated walkthrough of the two dominant important receptors in breast cancer, the estrogen receptors and the HER2 receptors. And of course, they're very important in terms of pathology, ER positive cases and HER2 positive cases, and patients can't often visualize things. So sometimes I draw pictures, and I thought I would make a video and put it out there to hopefully clarify and give you some insight onto how these receptors work and how they function. So first off, if we focus on the estrogen, the case of estrogen, it's often important to look at the sources of estrogen, and there's two dominant sources of estrogen in female physiology, and with ER positive cases, of course, they are very important to understand these, especially in relation to premenopausal cases and postmenopausal cases. So the ovaries, of course, most of us know that this is the dominant source of estrogen production in premenopause. So the ovaries, of course, cyclically will have different increases and decreases in estrogen production and release, but in the premenopausal case, generally we would say obviously it is the dominant source of estrogen, and I'll draw estrogen as E2 here. There's other forms of estrogen, estrone and estriol, but I'm writing in estradiol here. It's again more of the dominant estrogen in circulation. So in premenopause, that's where we get most of our estrogen. Now there is another source, of course, which I will draw here, and it is the fat tissue. So I could have drawn the liver here as well, but the fat tissue is a very important source of estrogen production, and predominantly in postmenopause. It becomes more important in the postmenopausal case, and that is because it possesses a very specific enzyme called aromatase, and we will touch on aromatase more specifically and in detail a little further on in the talk. But these are the two primary locations and sources of estrogen production. So if we move to the HER2 case, it's in a family of receptors called the ERB receptors. So this is ERB-B2. They're also in a class of receptors called tyrosine kinase receptors. And again, that'll become more important as we move forward as well. Just as estrogen is the primary trigger for the estrogen receptor, for HER2, it is the epidermal growth factor. We also call it EGF for short. So it is the main growth factor that stimulates the HER2 receptor. So where do we find these receptors? If I would draw a cell here for you, and there's the outer membrane I'm drawing, and internally we have the nucleus where we find the DNA. These receptors are found embedded in the outer membrane. So they actually have direct contact with the outside environment as well as the most interior compartment of the cell as well. So they cross that membrane. So any external circulating hormones I'm drawing here, they have direct access to the receptors, and again, the receptors can communicate interior towards the cell. So if I focus on just this membrane here, this outer cell membrane where the receptors are found, and if I magnify it for you here a little bit, and I'll do my best to draw what we call a lipid bilayer. Bi means two, and so the structure of the outer membrane of a cell is two sort of fatty layers stuck together as I just drawn here. And if I draw, we'll start with the HER2 receptor here. If I draw a HER2 receptor sort of embedded in the membrane and spanning across the membrane, we find it in its inactive form as a monomer. So meaning by itself, it's isolated by itself. And if I draw another monomer beside here in the membrane, another HER2 receptor, as we find it like this. And so the HER2 receptors are able to communicate the external trigger of an epidermal growth factor on the exterior membrane. It's like a docking area on the HER2 receptor. So when EGF binds the HER2 receptor, it's like flipping on a light switch, like when you walk into your room, and it triggers something. So when we flip a light switch, of course, in the case of walking into a room, we expect the lights to flip on. And in the same way, when EGF triggers and docks into the HER2 receptor, it stimulates and brings two monomers together as a dimer. So you see how they're sort of connected together there. And I mentioned previously, on the left there, we see it's a tyrosine kinase receptor. And what that means is on the interior aspect of the HER2 receptor, we find these tyrosine residues. And they're very important because they are connected to a protein called RAS. It's immediately on the inside of the cell, very close to the tyrosine residues on the HER2 receptor. And its job is to communicate the information that an EGF growth factor has docked into the HER2 receptor. And when that happens, the tyrosine residues turn on the RAS, and RAS communicates that information of that binding to another protein inside called RAF. And RAF's job is again to keep this cascade of information flowing to MEK and MAP kinase, MAPK, and both of them are turned on. I'll draw those little pluses there. MEK also continues to turn on another protein, so you see the complexity here, but it turns on ERK. And so starting with the EGF binding of the HER2 from the outside, we see internally, intracellularly, in the cell, we have ultimately the activation of MAP kinase and ERK. And it's not quite at the end point of the cascade, but we're getting close to the end result here. And to get there, which is ultimately in the nucleus of the DNA, we have what we call, these are now called transcription factors. And transcription factors can speak immediately to the DNA. But before I hop onto that, we'll pull in the estrogen receptor here, and I'll draw that. It can be found embedded as well. Here I draw it in blue, embedded as a transmembrane protein, so it can communicate with both the inside and the outside of the cell. And then we can also find it free-floating as well in the cytosol, which is the most immediate inner compartment of the cell. We can actually find them in the nucleus as well, free-floating. So the estrogen receptor has a little bit more freedom to move around, but it's also bound in the membrane. And we can see, again, the estrogen from the circulation binding on the outer aspect of the estrogen receptor. And as I said as well, because we have that free-floating estrogen receptor inside, estrogen actually has the ability to translocate before it binds. Without even binding, it can actually enter the cell and engage an estrogen receptor free-floating in the cytosol as well, just like this. So there's the estrogen, that little dark circle on top of the estrogen receptor. And so again, ultimately, what is the end result here? Well, if we move to the nucleus is where we find the real significance of these receptors and the information cascades that they have communicated. And it really takes place in the nucleus, which is the most interior compartment of the cell where we find the DNA. Now again, these transcription factors can directly, after they are turned on, directly engage the DNA. So I'll draw ERK here, for instance, and we can also find that estrogen receptor, once it's activated, can engage the DNA as well. So there it is. Now, if we extend the DNA a little bit here, the significance here, you'll see sort of the end result on what this means to the cell, its division, its activities and behaviors. Because along the DNA, we know that there are genes. I'll draw one here. I'll draw a couple here. There are genes along the DNA that have a direct impact in very specific ways on the activity and the behavior and the skills of a cell and how it acts. So if I draw 3 here, gene 1, gene 2, and gene 3, and in the case of the transcription factors have bound onto these genes, they have different activities. So before they're bound, before the transcription factors bind and influence these genes, I sort of draw a little volume here, a little volume symbol, that they're very low. But once we have the binding of the transcription factors, the activity, the impact, the volume of these genes, we call it gene expression. The gene expression goes up. And so particular genes that are designed to be influenced by these different receptors and cascades are increased in their volume of what they're saying to the cell. And so if I draw a little bubble here of what are they actually saying to the cell when these receptors are initially triggered and stimulated, we know that some things increase, particularly in a malignant cell, that proliferation, cell division increases. You may be familiar with Ki67 from your pathology, from your biopsies and surgical results. And Ki67 is a little protein that is only stained for. You can only find it during a cell dividing into two new cells. So we see Ki67 go up in a very abnormal way in malignant cases. Another survival skill that can be enhanced and exaggerated is angiogenesis, which is the drawing of new blood vessels to a tumor to bring more nutrients and vitality to a cell. Metastasis. So a cell has the ability to actually interact with its most immediate environment, and matrix metalloproteinases, MMPs, are a way. They're sort of like scissors, and they can cut through the connective tissue. And they can be very helpful to a normal cell, but when they're exaggerated, these scissors can cut through connective tissue and allow a cell to migrate and spread into areas it should not travel. And this is one of the main mechanisms to allow metastasis. And then another thing that can happen to a cell when these receptors are stimulated abnormally is that apoptosis is decreased. And apoptosis is happening when a cell is about to divide into two new cells. Apoptosis is the ability for a cell to proofread itself, and if there's any abnormalities or errors, it can actually kill itself. And it's a beautiful safety mechanism, but when that's decreased and all of these others, we know that we have some survival skills leading to cancer growth. Ultimately, what's happening is we're driving a cell through its cell cycle. So a cell can be very sleepy and dormant, not growing at all, but when it wants to divide, it enters the cell cycle, and CDK4 and cyclins, you see them here in the circle, they are very important and active to drive a cell through its cell cycle. So when these genes are activated and overstimulated, we have cyclins increase, CD4 increase, and we have a drug here, I just wrote in Ibrance here, and Ibrance is a new drug. It's also called palbociclib, and it's a CDK4 inhibitor, and so it's a new class of drugs that's often used in breast cancer cases. And it's to decrease that cyclin and CDK4 increase, okay? So that's the end result of all of these survival skills. There's others as well. It's sort of a summary of what can happen when these receptors are stimulated. So let's move into the drugs now here, and one's very common to us. We know tamoxifen. If I draw tamoxifen here as a little sort of a puzzle piece, tamoxifen is designed to engage the estrogen receptor and block it directly. So if I draw another estrogen receptor here in the membrane, and again, we know estrogen is going to be wanting to stimulate it externally. If tamoxifan's sitting in there, the estrogen that typically would have been binding and engaging that receptor is blocked, and it cannot stimulate and cause that downstream impact. Okay, it's a pretty simple, straightforward drug. If we look at the HER2 receptors, there are HER2 inhibitors, and there's two ways that HER2 receptors can be inhibited. One is by antibodies, and so first we have trastuzumab, also called Herceptin. We also have pertuzumab, which is called Perjeta, and by the MAB at the end of their names, trastuzumab and pertuzumab, that stands for monoclonal antibodies, MAB. So these are antibodies. And these antibodies are very specific. They are designed to bind on to the HER2 receptor. So if I draw an antibody here, if you remember from your immunology, if you took it, antibodies have sort of this Y shape. Okay, so trastuzumab and pertuzumab. And again, we're looking at, just like tamoxifen, blocking the estrogen receptor. If I draw these HER2 receptors here again, because I didn't want to mess up the left on the drawing there, but so I'll draw it again here, and if you can see the HER2 receptor in the membrane, and the antibody I'm just going to draw right on top here. So again, it's blocking the ability for epidermal growth factor to dock onto the HER2 receptors, and therefore, again, just like the tamoxifen did with the estrogen, the downstream signaling that we see from a stimulated receptor does not happen. So this downstream intracellular signaling from RAS down to RAF, down to the transcription factors, MAP kinase and ERK, that's blocked, okay? And there's another way actually that we can block the HER2 receptors, and that's from a drug called lapatinib. And lapatinib it's actually a tyrosine kinase inhibitor. And we know that from the NIB. If you see an NIB at the end of any drug, it's from a tyrosine kinase inhibitor. And of course, we know that HER2 is a tyrosine kinase receptor with these tyrosine residues. Very important to activate the internal cascade of signaling down to the DNA. It's also called TICURB, lapatinib. And if I draw it as a little blue square here, you can see that it does not block externally. It actually inhibits the internal signaling from the tyrosine kinase residues. So we could actually have the epidermal growth factor bind, but the cascade of events internally does not take place because lapatinib, being a tyrosine kinase inhibitor, blocks it. Actually, you can see these different HER2 inhibitors used together and in tandem. They can be used, like Herceptin and Perjeta can be used together. So there's two different ways. We've got the tamoxifen and we have HER2 receptors. Of course, we have to speak of aromatase inhibitors. And this is a drug class that's dominantly used in postmenopausal cases, as tamoxifen is usually used in premenopausal cases. And there's different aromatase inhibitors that you may be familiar with: letrozole or Femara, anastrozole or Arimidex. And then we also have exemestane, which is called aromacin. So these are all aromatase inhibitors that are all used in ER, estrogen receptor dominant cases. And they are mostly important in postmenopause, as I just mentioned, and that is because, as mentioned previously, the dominant source of estrogen production is no longer the ovaries, but it's the fat. And once again, we have an aromatase enzyme found in the fat tissue. And so what does aromatase do? Aromatase can take other hormones, like if I draw testosterone here, and it can take testosterone and convert it into estrogens. So even though we don't have direct production of estrogen from the ovaries, we can do it at the fat tissue. So the more adipose or fat tissue we have on, the more this takes place. And it is the aromatase that is inhibited by these aromatase inhibitors. So essentially the fat becomes this, if I draw a little factory here with some smokestacks. So this is like an estrogen factory now. And again, it's important, and we see clinically it's important with recurrence rates to get down to, as best we can, to an ideal body weight and decrease the factory. So aromatase inhibitors are really designed to shut down that factory in postmenopausal estrogen receptor positive cases. Okay? So if I summarize here, we've got two sources of estrogen production, the fat and the ovaries. Aromatase is in the adipose fat tissue to make that estrogen. In HER2 cases, we're dealing with epidermal growth factor. These receptors are found in the membrane of cells, of breast cells. And we can also find estrogen receptor free-floating in the cytosol. When they are stimulated from either of their respective growth factors or hormone, the estrogen, transcription factors are activated. They directly engage the DNA. They can exaggerate gene expression, and certain survival skills can be enhanced and exaggerated. Cell division, angiogenesis, spreading, and a decreased ability to sense error and shut the cell growth down. That is lost, it's silenced. And again, we have this increase, therefore, of cell cycle. We're driving a cell towards division. I mentioned Ibrance before. It's a CDK4 inhibitor. It can often be used with the aromatase inhibitors like Femara Ibrance can be used together to try to shut down breast cancer growth from sort of two different angles. Okay. And then we have these other drug classes as well, the monoclonal antibodies at the HER2 receptor, the trastuzumab and pertuzumab, and we have the tyrosine kinase inhibitor that works internally on the inner aspect of the HER2 receptor to decrease the cascade of events driving cell signaling, as we mentioned before. So there's another mechanism here. Actually, I forgot to draw this one in. Tyrosine kinase can also, the HER2 receptor can stimulate PI3K, which stimulates AKT, which ultimately stimulates the mTOR protein internally. And mTOR, again, can drive cell growth. So it can actually be a real dominant factor, again, turning on genes. I mention this because there's a drug called Afinitor. It's an mTOR inhibitor, and so you may find this in estrogen receptor positive cases. It's often used with like aromacin, for instance. So aromatase inhibitors. So we can find a regimen of Afinitor, aromasin Afinitor used in more of a metastatic case, estrogen receptor positive metastatic cases. So this, again, hopefully, I know it's a little messy, but hopefully you can rewind it or fast forward and listen to the pieces of this that over and over again, because I know it's complicated, but hopefully it's sensible and understandable and clear. The significance of these receptors, of course, is important in breast cancer, and so I wanted to highlight them for you. One thing I didn't mention, and I could, is really diving into natural compounds that can sabotage some of this as well. So for instance, there's so many examples of how natural compounds can do this, but the estrogen receptor, for instance, has alpha and beta types, and so the beta form is really good. It doesn't do a lot of this exaggerated growth, but the alpha form, I'll draw some X's here, we know that it is involved in metastasis, the estrogen receptor alpha, and there's natural compounds that can really decrease the expression of the alpha and increase the expression of the beta. And so if we can tweak this balance a little bit with natural compounds, at the same time in conjunction and safely using it with the other drug classes for receptor, maybe we can have an impact here. So hopefully it was sensible. Thank you for listening.